the slides available post-lunch and learn via HQIP forum and NQICAN websites as well. I'm just seeing some bits coming up in the chat, Marina and Sonia, about the correct links. I'm not sure if anybody can have a look at that. So if we move on to the next slide, I'll keep going and go on to the agenda for you. So today we'll be touching on the importance of Clinical Audit Awareness Week then and the wider QI community, and of course that focus today on how we utilise clinical audit to support sustainability and future-proofing health and care. So delighted to say that shortly we will hear from John Ashcroft, who's the Director of Pathways at NHSEngland, and that's regarding work nationally that is actually future-proofing and safeguarding our health and care into the future. Before we move on to announce the Clinical Audit Hero Award, obviously for this category of sustainability, we are going to hear the winner present their winning. Sorry, can I just get everybody to make sure they're muting? Sorry. We will hear the winner present their winning submission, obviously, and there will be the opportunity to ask questions. So please do keep posting in the chat as we move through the session. If we don't get a chance to answer your questions, we're going to put a Q&A document together post lunch and learn, and we'll make sure that we can publish those responses for you. We're going to try and close obviously at 1:30, but before we do, we've got an interactive evaluation on screen, and Marina, our General Secretary, is going to walk us through those questions. And then obviously, as always, we challenge you to take away something back to your own organisation to take forward on the back of today's topic about sustainability and future-proofing health and care. So we just move on to the next slide then, please, Sonia. Ultimately then, we're obviously all here to provide high quality and effective care to all in the right place at the right time, whilst preventing avoidable harm and providing that best experience for our patients and the best possible outcomes. That can be challenging at times, as we know, within NHS organisations. However, as always, we follow that 4 stages of clinical audit for improvement. We identify improvement, we measure for improvement, we implement the improvements, and then of course we evaluate and measure for the impact that those have had, and to make sure that we are sustaining in health and care as we're going forward. So this week's touched on drivers behind our programmes of clinical audit for improvement every day. Clinical Audit Awareness Week 23 is run in conjunction with HQIP and behalf of our local clinical audit community. This week has really provided us with the opportunity to share, network, celebrate together in terms of what we achieve every day. So it's not a week in time. We're basically using this as a week to stand back and reflect what's working, maybe where it's not quite right, and set ourselves some objectives to take away from the week back to our own organisations, teams and patient service users. Little bit of a recap on NQICAN for everybody then. NQICAN is currently made up of 11 regional networks. If you're not yet a member, we'll pop our nhs.net email address into the chat for you to get in contact with us. We'll direct you to your regional network chair. They've all been interactively leading their regions this week in Clinical Audit Awareness Week. NQICAN has got a common purpose and a forward plan to support us all with our improvement work back in our own organisations. We do hold open meetings, and the next one is the 29th of June, next Thursday morning, 10 AM to 12 PM, with an open access link that you can access via the forum or on the website. We get updates from NHSEngland, the Healthcare Quality Improvement Partnership, NICE, Getting It Right First Time and more. We have a national network and sharing forum as well that you can join and interact with colleagues around the country. And again, if you're not yet a member, we'll pop the link for that into the chat and you can register for that platform. More recently, we saw the launch of the National Learning and Knowledge Hub on the NHS Futures platform, focus around taking action on national clinical audit findings. And that's a community coming together where we can support one another to celebrate where we've achieved quality improvements for our local communities. We can provide examples and case studies of how to make things even better. What's worked in one organisation could then be taken forward in another. It's in its infancy, it's going to evolve as we network and share, building that repository of resource for us all. So we'll pop in the email address into the chat as well so you can get in contact with the transformation team to ask for access to that platform if you're not yet on there. HQIP have published a quality improvement magazine called Cornerstone that was launched, new online free publication designed to support quality improvement in health and care, and that's available through the Healthcare Quality Improvement Partnership website. So we'll pop that link in as well into the chat. Aware there's quite a bit going into the chat, but you'll be able to scroll up and down afterwards if you miss it whilst you're actually in the event as well. So just a really quick reminder before I go on to the next couple of slides before I hand over to John then, it's just about thinking as you go through this session, as we have done across every day of the week, what can you actually take away that you could then take forward in your own organisation, teams, and with patients and service users. So if we just move to the next slide then and framing today's topic for you all, it's about the NHS really in health and care balancing its responsibility to meet immediate healthcare needs with that responsibility to actively promote health and prevent that illness. And it's about ensuring that we can continue to provide high quality care into the future. So sustainable commissioning is about future-proofing health and care. This means ensuring better outcomes for patients both now and in the future, despite increasing resource constraints. It's about equity, sustainability and efficiency. And all three of those domains have now been added into the domains of quality, where previously it was all about safety, experience and effectiveness. They've actually added those in now. So we must measure and drive sustainable improvements in care, embedding sustainability into everyday practice, building a health and care system that's actually ready for the future. So if you think in 10 years, 20 years, 30 years, what do we want our healthcare system to look like for us? We're all working in it. So we've now got almost that duty of care to make sure that we get to where we need to be. In Clinical Audit Awareness Week 22, you'll see here that we challenged you all to go back to your own organisations and consider sustainability in your clinical audit strategies, your clinical audit programmes, your clinical audit findings and action plans for improvement. And we'd love to know how you got on. So you can post in the chat to let us know how you found that in the last 12 months. But it was thinking about aligning that strategy with addressing the equity and sustainability. It was making sure the clinical audits are measuring those new technologies and ways of working, and also that your findings and action plans focused on those new innovations and care models. So finally, we'll just have a look at what you told us last year on the Menti before we hand over to John. You told us what sustainability and future-proofing health and care meant to you, and it was around using your clinical audit outcomes to support health and care, planning for the future, that remeasurement or that continuous measurement to assure impact of improvements are sustained, making the results meaningful to the audience to inform that action, co-production, linking your audits to your organisational objectives, and collections of metrics through electronic systems as part of routine care, and reducing data burden and releasing that time to act. And then there was a really, really good comment in there around timely review and understanding of data to inform decision making for taking action to improve and strengthen health and care for all. So last year, when we touched on sustainability and future-proofing health and care, we heard from James Mountford, and he mentioned that the delivery and continuous improvement review was underway, and we had the heads up last year, but maybe we didn't really see the detail at that stage of what it's going to mean for clinical audit. That review has now been published, and we've seen the launch of NHS Impact, a single improvement approach for the NHS. So we're all excited to be working closely with NHSEngland on ensuring that we do understand this and that we can apply this locally for our clinical audit programmes. And yesterday afternoon at the NHSEngland event, we heard from Vin Dawakar, the Medical Director for Secondary Care and Transformation at NHSEngland, and Michael Sykes, who's a Senior Research Fellow at Northumbria University, but also the QI Lead for the National Diabetes Audit, on his research around audit feedback and taking action on audit results. If you missed that event, do please access the recording and slide pack on the NHS Futures platform. And as I've said, we'll add the contacts in the chat for you to request access to that platform if you're not already registered. But finally today then, as we end Clinical Audit Awareness Week 23 with sustainability, We're absolutely delighted to be joined by John Ashcroft, who is the Director of Pathways at NHSEngland. And John has over 10 years' experience of operating at executive and board level in a range of healthcare organisations, and was previously the Chief Executive of Manchester Royal Eye Hospital and University Dental Hospital of Manchester Trust. So I'm going to now hand over to John.
Oh, thanks so much, Victoria. Hi, everyone. Can everyone hear me all right? Yeah. So if anybody saw, so I work for Vin, and if anyone saw him speak yesterday, apologies that you've got a very poor substitute in me today, but I will do my best. So thanks so much for having me. I'd just like to start, if it's all right, just by telling everybody a sort of story about not my sort of career history, but how I decided to sort of join the NHS. So when I was 19, my mum had a routine mammogram and was called back to be seen at the hospital, and I went with her, so she didn't go alone. And we went into a clinic waiting room, and there's about 40 women in there, and in the space of about an hour and a half, about 35 of them went in to this one consulting room, came out looking very relieved and very happy, and just walked out. And after those 35 women had gone in, there was probably a pause of about 10-15 minutes. So there's 5 very worried women and partners, families sort of sat there. And one by one, they went in. About 10-15 minutes later, came out looking absolutely devastated. And my mum was the last woman sat in that room. So she knew she was going to get some really, really awful news. Went in, got some awful news, came out, really upset. And at that point, we were asked by the cleaner if we could move out of the clinic room and the sort of waiting area, because they needed to get it turned around for the clinic in the afternoon. So I should have said at the beginning, spoiler, my mum did have breast cancer. She's recovered from it, very, very lucky. But at that point, I decided I wanted to come and work for the NHS, because I sort of thought I wouldn't want anyone to go through the experience she had gone through. And it's something that really, really does stay with me. And I think if you think about that experience in terms of any kind of waste, like, movement, anything that was going on, there was no way that was high quality care. I'm sure it wasn't satisfying for the clinicians working in it, and didn't give sort of patients probably the outcomes they wanted. So it is something that always sort of stays with me and always comes back to me in terms of thinking about what the work that we do, trying to make things better for patients, but also one of the reasons why I'm really, really pleased and excited to be leading the NHS impact work. As Victoria's kindly said, I used to be Chief Exec at Manchester Royal Eye Hospital. Really, really great organisation, really proud that we got the CQC Outstanding. I thought that we had really sort of embedded quality improvement approaches. And we did do some really good things, largely down to some of our sort of clinical effectiveness and audit team around reducing the amount of harm that was coming to patients on, say, outpatient follow-up waiting lists. But I think if somebody was to say to me, did we have a sort of embedded management system where quality improvement was the go-to method for every problem we had? So how we dealt with our sort of financial issues, did we really look at how we sort of procure a lot of our items? The answer was probably no. So as I say, I'm really, really excited to be here to talk to you about this today. I'll get through the presentation in the time that I've got, and it might even be a bit quicker if people have got a question or two, because I know we've got a presentation at 1 o'clock. So I could have the next slide, please. So first thing to say is building on from what you've heard from James Mountford about the continuous delivery improvement review. Amanda made a really public commitment when she launched NHS Impact, and explained really passionately and eloquently why this was so important to her. And I've talked a little bit about why it's important to me, but fundamentally there is an evidence base, and we know that organisations who use quality improvement, who've got it sustained and continuously focus on knowing the business, improving it, do deliver better outcomes for patients, better performance, better staff experience. And there is a growing body of evidence about what that looks like in organisations. And there is also evidence starting to emerge about what that looks like across systems as well. So it's really important that it's not just a sort of passion project. There is empirical evidence about why we are doing this, and there is a strong correlation with organisations who've got a CQC outstanding rating and their systematic approach to quality improvement. So really clear evidence base around this. Could I have the next slide, please? Which was why there was then the delivering continuous improvement review. So the review was led by Anne. James Mountford might have talked a little bit about it. Really strong sense of engagement and co-production, not just staff, but sort of patients, lived experience, partners, leaders who have done this in organisations, local government were involved, and a wide range of people. And then I think we're going on to the next slide. So in February of this year, NHSEngland board approved the endorsed the three main recommendations of the review, which was number one, to launch a single shared NHS improvement approach. So that is not saying that everybody has to use lean methodology or everyone needs to go and get trained up by the IHI, but it's saying that every organisation has to have an approach to improvement, and that should be their go-to method. Second was to establish a national improvement board, agreeing a small number of priorities that we want everyone to focus on, so that we're really using our existing assets and our improvement capability to deliver improved quality in a smaller number of areas than we probably do at the minute. And the third was to co-design and establish a leadership for improvement programme. As a result of a number of the reviews that have recently happened, working very closely with the workforce education training team on what a leadership for improvement programme would look like as well to support building capacity. So that was February this year. If we could have the next slide, please. So the Amanda launched NHS Impact on the 19th of April. And one of the things we did at that session was to ask the trust and ICB CEOs who are in the room, what would need to be true, or what do you need from NHSEngland in order for you to do this as organisations? The other thing that was really interesting to note was we did sort of ask people, how many of you in the room would say that you've got an embedded management system that really allows you to deliver continuous quality improvement? And probably about 10 people probably sort of put their hand up. So we know that we are starting from a comparatively low starting position, and that this is a journey that is going to take time. But some of the things really interestingly that we heard and sort of asked to hear from the people in the room about what would need to be true to make this happen were things like, well, actually, we need NHSE to role model this kind of behaviour, rather than it being, we're instructing everyone to operate one way, but we're going to keep doing things different. We're going to keep doing things as we've done and not change. Second was about how we use data, because we are, I think, very often lapse in the centre into looking at sort of snapshot reports and then saying, well, phoning someone up and going, well, why was your performance bad yesterday? When actually, if you look, they might be improving over time, and it's, natural variation. So had some really, really helpful insight and feedback from people about what would need to be true in order for them to begin to embed a sort of continuous improvement approach and really start moving towards the aspiration that Amanda set out around NHS Impact. For those of you who haven't seen the website, I'll make sure there's a link popped up in the chat, and there is a slightly longer read version of some of the information, I think on this slide and next slide, that is basically a summary of the review that James spoke to you about previously. And it sort of sets out the 5 components, if you like, the core DNA of all evidence-based improvement methods, given there are a wide range of them. And it is about building a shared purpose and vision, investing in your people and culture, developing leadership behaviours, building improvement capability and capacity, and embedding improvement into management systems and processes. And I think on the next slide, there is a little bit more detail around each of these, which I won't go into and sort of read about all of them, but I would encourage people to look at the website if you're interested, or get in touch with me or a member of the team. So can I have the next slide, please? So we are looking to establish a national improvement board, and it will set a small number of shared national priorities and I think have a really strong focus on creating the right context in which continuous quality improvement can be delivered and will be our sort of go-to method for working. We're currently in the process of recruiting, I think it actually sort of closed yesterday, a chair and deputy chair for that, because we think it's really important that it is by people who have got lived experience of doing this, and that it wouldn't work very well if it was just, you know, myself or someone who's now in a national role saying, look, this is how everyone should do it. So we are really, really thinking carefully about how we construct that, making sure that we've got the right range of individuals on it, and we will also, I think, be going out for a national clinical director as well, to make sure that we are being clinically led as well as excellently managed. So we are hoping, I think, to announce early next month who those individuals are, what the board looks like, and looking to get the first meeting set up as soon as we realistically can. Can I have the next slide, please? So touched a little bit on the Leadership for Improvement programme, and there's a lot of work happening within the workforce education and training team, looking at a range of leadership programs in light of the Messenger review and a range of other reviews. And I think it's really, really positive and exciting that there is going to be a specific Leadership for Improvement program within that. Amanda made a really public commitment that all members of NHSEngland will have to have a base level, at least a base level amount of training in quality improvement. So I think it is really, really positive. And I'm conscious that the sort of individuals we've got on this call are probably people in their organisations who are really used to working in this way, and continuous improvement being embedded absolutely in clinical audit effectiveness is something you do. But I think it's really, really positive that we're looking a bit broader than that, because certainly my experience of working as sort of chief exec director of operations, we are often much more in the space of just make something happen rather than testing things out, measuring for improvement and measuring for that performance improvement, rather than just saying has the target shifted. So I think it's a really positive development. The training is not just for trusts, it is for boards. We have had a lot of conversations, as I said, with sort of local authority partners, and we want to be as generous as we possibly can with all of our materials, which is why the web link that Helen's really helpfully put in the chat is open access. It's open to everyone, because we're really conscious of the great work that systems are doing in bringing together partners who are not NHS organisations or employees, and making sure that we are working in an inclusive spirit. If we have the next slide, please. So as I said, we've sort of we've got the link in the chat there. If anyone's got any questions, that is the mailbox. I think what we're looking to do, we've been doing quite a bit of work around, is, as I said, announcing who the chair, co-chair are going to be, advertising for the National Clinical Director, and then I think really using that board to drive, as I said, the context, if you like, and making sure that we've been really clear about what we think that context needs to look like, what we need to do differently, and making sure that we are really effectively working and making best use of the assets we've got, because it's not like we're starting on a greenfield site with this, and everybody, I'm sure, on this call and their organisations are doing a huge amount of work every day. I think it's about how we do it in a more sort of coherent and cohesive way, and really get the impact for our patients, and particularly for our frontline staff as well. I think that is probably the last slide, near the last slide. So I appreciate we've not got a huge amount of time before the next slot. So if people have got any thoughts or reflections now, or want to share via the sort of email, and Helen, if you could pop in the chat what the email address is, we'll be really keen to hear from yourselves and engage in conversations with you going forward about how do we make the most of this opportunity, and what resources can we sort of effectively co-produce, and what would make the difference to you guys. So I'll stop there. Conscious we've only got sort of 5 minutes before the next slot, but I'm really happy if anyone's got any questions or comments or anything they'd like to share.
Lovely, thanks, John. So has anybody got any questions? Would you like to raise your hands, and we'll go down in order? Nobody's raising their hands at the moment. Have we had anything coming up in the chat? I'm conscious we've popped lots of links in there for you so that you can access and register everywhere that you need to. I'm not seeing any questions coming up in the chat at the moment, but I think we've got a hand. Joanne, over to you.
Hi, thank you very much for a really interesting talk, and it was really helpful to hear that personal story at the beginning that I think is a reminder to us all about why we do our jobs. And I totally get that that can stay with you for a very long time when you see things that aren't as good as they should have been. My question really is just about, in terms of sustainability, there doesn't seem to be any mention in the NHS impact about environmental sustainability, although you did refer to supply chains and things like that. It isn't sort of explicit in there the way I might have expected it to be with the targets that we've got for NHS net zero. Is there anything more that could be put in there to remind people that those things are important as well?
So I think that's a really, really great suggestion. And I always need to check myself when I talk about, the importance of clinical and financial sustainability, which is what I've done for the past 20 years. I've been in the NHS to make sure that we're talking about clinical, financial and carbon sustainability as well. We really need to be championing that. So I'd be really, if you've got any specific suggestions, John, I think it'd be really, really helpful to hear them or maybe have a follow-up discussion. In terms of the review, that has now been sort of published, but I think in terms of the website we've got, that is a sort of starting point. And I think what we're really keen to do is make sure that one of the things we heard in the review, it's often quite confusing. Lots of great stuff on sort of buried on NHS Futures. GIRFT has a separate website. So how can we pull all the best, a smaller number of more easily navigable materials in a single place? So at the minute, we've got information about, I think, elective recovery, UEC, we've got some stuff about primary care, but there is an ambition to really build that out and have NHS Impact as the main sort of repository of a lot of the great materials that are dotted everywhere. So I think there is a desire in future to put stuff on there. So I think we will absolutely have the work of the net zero carbon team on there. But if you've got any other suggestions or thoughts or reflections, it'd be really helpful to hear about how we can have that foregrounded a bit more.
Thank you. I'd be very happy to liaise with you a bit more, but I think the key point from my perspective is that in order to engage our leadership, it really needs to be in high-level demands on trust so that it gets that priority.
Thanks, Joanne.
Thanks, Joanne. That's brilliant. And it looks like, Brid, you've got your hand up next, please.
Oh, thank you. And thank you, John, for informing me about this improving care together. I wasn't aware of it, so that's great. And I just had a quick look at it. And underneath each of the broad statements, the 5 statements, obviously, there's loads of areas to focus on. And which looks a mammoth task, to be honest with you, and an ongoing continuous improvement. But I was wondering, as we go on this learning journey together, where we could share ideas and support each other on work programs that have been done, rather than we all doing it in isolation, and whether we have that facility available.
Yeah, so I think that is a really, really great point. So I think that one of the conversations we've started to have, with and through sort of regions and systems is about, well, what are the networks they've already got? How can we make better use of that? So I was tasked with running the Winter Improvement Collaborative at the back end of last year, which probably wasn't a collaborative in the true sense of the word. And for anyone who doesn't know, that was about how in a rapid 10-week period of time we could look at reducing ambulance handover delays. And what we did there was bring together people, and we asked them to self-select what area they were working on and brought people together nationally. And the 2 bits of feedback we had out of it were, number one, people really, really valued the space where they're able to connect with peers, and not necessarily peers who are just within their system or region, but people they wouldn't usually get to talk to in terms of sharing their learning and their experience. So I think that there are a number of structures that exist already nationally. There's lots of structures that exist in systems and regions. There's lots of communities that I don't think we're really tapping into at the minute around how we do that. So I think what we'll be doing is not nationally prescribing how best to do that, but thinking about how we can work with systems to make sure that we're making best use of what people have already got and where there might be opportunities to share things nationally. So it's a really good question. We definitely don't have the answer at the minute, but it is something we are working through how best to do, and are really starting to get into co-producing with regions and systems how best to do that.
And I'm just finishing off this and that, but I want 10 minutes. But we'll.
Oh, thank you. I was about to say some. Can we just make sure we're all muted, please? Thank you. Excellent. Sorry, John, had you finished talking then?
Yes.
Yeah, lovely. Thank you. Yeah, Di Lynch, one of our regional network chairs, just popped in the chat there that perhaps some of this could be taken through our NQICAN regional meetings. So again, Sonia's popped the NQICAN email address in the chat. So if anybody's not yet a member of the regional network, get in contact and we'll put you in contact with your regional network chair as well. If we've just got 1 minute, somebody's popped in, when is the Leadership for Improvement programme being launched? Have we got a time frame there?
Yeah, so that's a really good question. I think the intention had been to talk a little bit about it at Confed, but for a whole series of reasons that didn't happen. I think that in sort of September, October time, there's likely to be more information coming out about that in a bit more detail, is my understanding of it as things stand.
Brilliant, thank you. And I think then, as we're just 1:01 at the moment, we'll just, if we could move the slide pack on then, Sonia, we'll hand back to yourself, John, to make some announcements.
Okay, thank you very much. So I'm really pleased, I'm delighted actually, that it's time for the Clinical Audit Hero Awards. So these awards are a real opportunity to recognise, share and learn from the great work that's taking place at the minute to improve quality of healthcare for patients and users of services. And the Sustainability Hero Award specifically recognises clinical audits and projects that support sustainable healthcare services. So back to the point Joanne was making, so absolutely delighted to be talking about this. So I understand there were loads of great entries for this award, but there's one team who their exceptional work and commitment set them apart as a true champion for change by reducing carbon footprint to create greener and more resilient NHS. So I'm absolutely delighted to announce that the winner of the Sustainability Hero Award is Amanda Van Vuren, Deshana Dacker, Matt McDonald, Connor Brown, consultant anaesthetist and junior doctors at Sandwell and West Birmingham NHS Trust. So can everyone please join me in congratulating our winners? And I can see everyone's used to being on Teams because everyone's clapping virtually rather than coming off mute and creating havoc there. So for anyone who doesn't know, the team was recognised for identifying an opportunity to increase the number of total intravenous anaesthesia cases, which has a significant impact on the reduction of volatile gas-based emissions, supporting the ambitions of the NHS long-term plan and the net zero campaign, aimed for the NHS to be net zero by 2040. The judges were really, really impressed by the project's awareness and training campaign, which involved teaching afternoons and how-to troubleshooting videos. So I think it's at this point they'd like to invite Amanda, Deshana, Matt and Connor to share their journey, the incredible work they've done promoting sustainability through clinical audit. And I'm sure everyone will give them another round of virtual applause again before we hear from them. So thank you very much, everyone.
Hi, everybody. And well, first of all, am I communicating effectively? Can people hear me? Yeah, great. I just want to say what an immense honour it is to be here on behalf of the team to accept this award, and also to be here alongside so many dedicated and senior people who are committed to driving the NHS forward through the process of audit and ultimately delivering better and more sustainable care for our patients. So yeah, it's a real privilege to be here today. I'm just going to take you really quickly through the project. I appreciate that I'm going to have to channel my inner Chris Whitty here, aren't I, to do the slides, but I appreciate that I'm not talking to a room full of geeky anaesthetists here, so I'm going to, if I could have the next slide, please. I'm going to start by describing what TIVA is in a little bit of detail, and then just take you through where we were coming from in terms of initiating this project. You know, what the kind of results of the various tools we deployed to analyse the situation were, and then through some of the interventions that we decided upon, and finish up with some personal reflections about my own journey through developing a greater understanding and appreciation for the process of audit in all of this. So if I could have the next slide, please. So TIVA stands for total intravenous anaesthesia. When we take people to their happy place in the anaesthetic room, we normally use volatile gases. So at the bottom you'll see there's two compounds called desflurane and sevoflurane. And these are certainly sevoflurane more than desflurane now, because desflurane is very polluting. These tend to be the kind of go-to things that anaesthetists will reach for when they're getting someone off to sleep, and when they want to sort of maintain them in a deep plane of anaesthesia to allow the surgeons to do all the clever things that they do. Total intravenous anaesthesia doesn't use any gas. It uses two drugs called propofol and remifentanil, and it uses them via a series of pumps with some measurement of effectively an EEG, so similar to the sort of multiple leads you see on people's heads sometimes when looking for seizures and stuff. We have some technology that kind of gives us some composite numbers from that, so we can tell how deep asleep someone is when we're using the medication. In all of this, there is some debate in the anaesthetic community about whether this technique is greener. The vast majority of people accept that it is. And on this slide, this is essentially a kind of cradle to gate analysis of every bit of carbon that is involved from the production of the drugs all the way to their usage and ultimately disposal. So the numbers at the bottom are essentially what I'm trying to draw attention to here. And these are numbers sort of generated from a presumed 7-hour case, which obviously in terms of the kilograms of CO2 emitted are substantially lower for the intravenous agents than the gases. If I could have the next slide, please. Again, this slide demonstrates CO2 equivalent emissions that are associated with the gases. So the top graph is the actual CO2 equivalents of the gases when they're released into the atmosphere. And no matter how careful we are, there will always be some gas release into the atmosphere, following a case, because the gas will be coming out of the patient, it will be exhausted out of the theatre and so on. So there are things we can do to minimise gas release, but we can never completely avoid it. You'll appreciate desflurane there has a really substantial kind of CO2 equivalence, and the other two gases slightly less so. But if we look at propofol, it essentially has obviously zero emissions from direct release. And then if we look at the graph below that in the blue, which is, if you look at the scale, an order of magnitude kind of lower, even when we're just looking at the CO2 costs of manufacturing the agents themselves, propofol is way, way lower than all the others. So in both its manufacturing phase and in terms of its usage in theatre, propofol certainly has a far lower kind of carbon cost than the gases. Could I have the next slide, please? And this moves me on to our motivation for undertaking this project. We're all aware of the climate emergency, obviously, and whether it doesn't feel like it in our day-to-day existences, it is going to be what defines the next few decades of human existence. And it's not hyperbolic to say that this will be the greatest challenge that humanity has ever faced in its entire history. I mean, it is going to make the COVID pandemic look like a trip to the fairground, and it is going to dwarf the scale of even the two world wars at the beginning of the century in terms of the amount of displacement and death and immiseration that it's going to cause. The positive side in all of that is we still have the power to do something about it. We still have the power to change it, and change it we must. We owe it to ourselves, and we owe it to our species to do everything we can. you know, we're living through it right now. There are heat waves, there are floods, there are fires, there are droughts, and these aren't just environmental phenomena. These will have a real and tangible effect on healthcare services and, you know, kind of disease burden that we encounter as practitioners. To take one example, in the 2022 heat wave just in the UK, there were over 3,000 excess deaths just from that alone. And those are the sorts of numbers that are, you know, a very small slice of the wider problem. This is what we're going to be dealing with. And that's before you get onto the ecosystem effects of disease spread and all the rest of it. So this is going to be a fundamental challenge for healthcare in the 21st century. There's no two ways about that. Can I have the next slide, please? So the NHS have responded robustly to this, certainly in terms of their vision, and I know these documents will be familiar to most people. Delivering a Net Zero NHS was compiled by Sir Stevens in 2020 and sets us all the ambitious target of complete net zero in terms of our in-house emissions by 2040, with front loading to achieve 80% of that number by 2028 to 2032. Now, 2028 is 5 years away, and we are not where we need to be to achieve that target at the moment. Can I have the next slide, please? Can I have the next slide, please? Sorry. Yeah. So within the report is this slightly depressing pie chart of doom, detailing, you know, all the different carbon emissions from different sectors across the NHS. For us as anaesthetists, you know, the challenge that exists in this is the fact that some 5% of these emissions, and that is 5% of the whole NHS budget, which makes up 4% of the total UK carbon emissions. So this is a not insignificant problem, is actually related to anaesthetic gas usage. It's simultaneously depressing, but also sort of empowering in that we are in a kind of unique position to make quite a substantial impact on this pie chart. And, you know, we as a profession, you know, need to rise to this challenge. Can I have the next slide, please? So just to take you really quickly through the audit itself, our aims were essentially to increase the number of cases that were being done under total intravenous anaesthesia. And we targeted 2 theatres where much of the same equipment that one would need for a TIVA anaesthetic was being used, and only small amounts of change would be required to sort of bring about the behavioural shift. The focus is really on changing a culture and enabling trainees who are coming through the ranks to be more confident with the technique and incorporate it into their kind of regular practice. Because a lot of seasoned consultants who've been turning on the gas for 30 years will find it very, very hard to break that habit. Whereas if we can kind of get people earlier when they're forming habits, it's gonna have a significant impact. Can I have the next slide, please? So I think I've essentially covered these. So our objectives were to improve our sustainability and to essentially change the culture. We did this, we analysed our data in a 2-pronged fashion, auditing what we were doing in the 2 theatres that we were specifically targeting, and also having a chat essentially via a survey with consultants and senior doctors, but also trainees, which we did separately to gauge attitudes, you know, potential stumbling blocks, and, you know, the desire for change amongst the staff. Come next slide, please. So these are the numbers. I will rush through these. I'm conscious of time, but we looked at 104 cases over 6 weeks. We used some clever wizardry to try to estimate the amount of gas that was being used. It wouldn't have been mil for mil accurate, but it was kind of as best we could do, looking retrospectively through the records, and we applied it across the board. So can I have the next slide, please? What we found was part of mitigating the damage of gas usage in theatres is something called minimal flow anaesthesia, which essentially means sort of turning the flow in the circuit that we've got connected to the patient down to the lowest possible level, obviously to ensure that they're safe and oxygenated, but to minimise the amount of gas that's being pumped into the exhaust and then out into the atmosphere. We found first, so we looked at this first of all because minimal flow anaesthesia is a sustainable technique, and for some people, some people argue that it's more sustainable than TIVA. I don't agree, but there is a debate about that. We found that we weren't achieving minimal flow anaesthesia at a very satisfactory level. Hopefully these graphs sort of demonstrate that to some extent visually. Can I have the next slide, please? And what we found with TIVA specifically was that essentially there were no TIVA cases in the theatres that we looked at. So 6 weeks and 0 cases have been done under the technique. Can I have the next slide, please? We did some retrospective analysis to look at sort of average CO2 emissions in the theatres that we looked at. Based on the kind of how high the flows were that people were using, which affects the CO2 equivalents in terms of the pollution. And this graph kind of demonstrates that TIVA would have clearly had a significant impact in terms of CO2 emissions were it to have been employed routinely across both theatres. Can I have the next slide, please? There were a few things we did in terms of estimation that were likely to have underestimated this figure, to do with the kind of algorithm we used to calculate the CVO and to do with where we were looking at the CVO numbers. So we were looking in the middle of the case. Often when you're putting someone off to sleep, you use quite a significant higher flows at the beginning of the case just to get the gas in and get people off. So we didn't include the period in the anaesthetic room where there was likely to have been a much higher kind of more significant usage of gas than what we were accounting for. So essentially, the data we collected showed that TIVA would have been a vast improvement in terms of CO2, and we were also significantly underestimating what we were doing. Next slide, please. Again, this is probably a little bit technical, but these are the BIS monitoring, which is the EEG monitoring I was talking about earlier, and the other medication used in TIVA called remifentanil. A lot of people were using BIS monitoring and remifentanil in conjunction with gas. So these slides sort of captured how many cases were being done with all of this extra stuff, which contributes massively to the kind of CO2 cost of a TIVA case. So it strengthened our case for saying, all we need to do is put a couple of syringes of propofol in here, and we can just eliminate the gas altogether and make an even bigger improvement than the one that our previous data suggested. Can I have the next slide, please? I'm going to bounce through these quickly, but these were the results of the survey. Essentially, we found that there was a strong desire amongst trainees in particular, and also consultants and senior doctors, to improve the sustainability of their practice, which was really encouraging. Next slide, please. And there was, a general majority opinion that TIVA was more sustainable as an approach. We can flick through the next 3 slides because these are slightly more niche. So in those, we kind of looked at the knowledge and skills barriers that existed to TIVA, how confident people would be initiating a case independently, or in the case of consultant, how confident they would be to kind of take a trainee through the steps of TIVA. In doing so, we were trying to essentially identify the willing and the desire for change, and also any barriers that would exist to implementing it. So from all of our work, we identified several barriers to the change that we wanted to see. Some of these were equipment based, some of these were drug based, and some of these were skill based as well. So in terms of teaching and training and confidence and so on. Come on, next slide, please. To address these, so these are just the sort of conclusions that we came to, and essentially, we sort of reached the notion that there was significant ways we could improve the sustainability of our practice, even if it was still using gas, to use it as a sort of minimal flow, but also in terms of rolling out TIVA, that actually there were easy ways and easy wins that we could accomplish as well. Next slide, please. So these were the interventions that we proposed from our initial audit. And we ran the teaching afternoon as advertised there. That was very well received. We showed some videos of BIS monitoring setup and just sort of rudimentary skills that one would need to establish a TIVA anaesthetic. It was well attended by trainees from various hospitals and generally well received in terms of people's confidence levels in initiating TIVA anaesthesia. We successfully advocated for greater equipment in terms of pumps and BIS monitors. We struggled with getting the drugs changed to drugs that were more kind of suitable for TIVA usage, and this was something that kind of slowed the project down because we were waiting for the drugs to change before we carried on with further interventions. So that was definitely something that we learned from this in terms of how difficult it is to change processes, you know, with pharmacy and so on. Can I have the next slide, please? So this was our plan, and in fact we're currently at the end of TIVA week at our trust. So we've initiated it. We've gone ahead with it without getting the drugs that we wanted to get in place for it. We have had the extra monitoring. We have put in some extra support for people. We've had TIVA divas on site to kind of help people troubleshoot. We've put some videos and other resources online. We've put some posters up in the theatres. And it'll be really interesting to see what level of engagement we've had from people. I've had some very positive feedback about it so far, but entirely anecdotal for now. So we are, you know, this is an ongoing project where we will be collecting this data and then looking at another 6 weeks of data going forward to see what impact we've had on the overall numbers. Can I have next slide, please? So overall, we changed the conversation in our department, I think, about sustainability. We certainly made people more aware of minimal flow, and you know, it's become a bit of a theme on our WhatsApp groups now. Sometimes people kind of show the flows they're at in a case in the middle of it, and we sort of see who can show the lowest flow that they're operating on that day. And we've performed this intervention in terms of training that was well received by the trainees. And so far, there's definitely, it sounds like there's more people doing TIVA than there was before. We do need to go back and look at that data formally and kind of represent what we're doing and, you know, potentially keep thinking of new ways to change things. But it feels like it has had an impact both in terms of conversation and practice. And ultimately, that's what we're going for to achieve a cultural shift in the longer term. Can I have the last slide, please? I think it's the last slide anyway. So for me, this journey took me from the position of being someone who is contractually obliged to do audits to, you know, meet portfolio requirements, to someone who has a much fuller and more respectful stance with respect to the audit process generally. It was really empowering to be able to combine a really key personal interest of mine with processes in the NHS and to achieve changes, because I mean, the NHS is such a massive organisation. Sometimes it can seem a bit daunting in terms of how you affect things, but the beauty of the audit process for me is it's that sort of marginal gains, you know, Team Sky type approach where you break down all of your processes into their constituent parts, and you say, how can we get 1% better at everything? And if we achieve that over the board, we will deliver better care and we will be more sustainable and we will achieve all the things we want to do. So it's about all of us breaking it down and taking one piece of that jigsaw on at a time and just working hard to make those gains. I was really fortunate in all of this to work with Dr. Van Vuren, Dr. Dacker, who are excellent mentors, but also Connor, who was the colleague at my level. We're both sort of anaesthetic registrars now. He had a background in management consultancy, which, to be honest, I've never really understood what a management consultant does before I met him. But he had a really interesting take on analysing processes and, you know, achieving sort of smart, you know, specific, measurable, achievable, relevant, time-bound goals, and focusing in on how to sort of use a process of QIP to make genuine changes. So it was a real honour to work with him in all of this. So yeah, this is the process by which I came to understand audit better, and I hope to use that going forward in terms of helping to make the change that we all need to see. I think that's my last slide, but if you could move on just one more thing. Yeah, okay, we're done. Thank you very much. I'm happy to take any questions.
That was fantastic. Well done. That was really, really good. And do you know what I really love about it? And I know all the effectiveness teams that are on the call will do as well, that you so passionately delivered on a junior doctor-led project, haven't you? And you can really see the valuable learning experience, which we try and channel all junior doctors into. Don't just do something for your portfolio. Do something that's going to really give you an enriched learning experience of clinical audit and wider QI as well. So it's really good. Definitely. So I think we'll move to questions now, if that's okay. So I know there are a couple in the chat that I've picked up, but I was just going to see if we've got any raised hands. I'll keep an eye on the raised hands, but somebody's popped in whether this is going to be rolled out nationally, this project.
I would be absolutely delighted to work on that with anyone who wanted to do so. I'm part of a group called Green Anesthesia, the Green Anesthesia Intensive Care Network. Almost forgot what it stood for then for a second, but GAIN. So, you know, we collaborate on different projects across the board. A project they're doing that I'm really excited about and I want to take on going forward is about reducing nitrous oxide use, because reducing actually what they've looked at is how nitrous oxide is leaking from the kind of main storage units that we keep it in through the manifolds that it's delivered. So there's a lot of nitrous oxide just escaping out of our pipework without ever being put to use clinically, and it's a really significant contributor to global warming and climate change. I mean, it's worse than the sevoflurane. So I think that's of all the kind of projects on the horizon, that's probably the most effective win. But I'm definitely going to keep advocating for TIVA, and I'd be absolutely delighted to work on that with anyone who wanted to, really.
That's brilliant, thank you. And Catherine, you've got your hand raised.
Hi Vicky, it's actually Zoe from Ramsey. Hi,
you're coming up under a different name, but
yeah, I am. Yeah, Kathy's logged into the presentation and the learning lunch, and I'm sat in the background doing some analysis, but I've been listening in as you've been talking, and it was just really regarding that last presentation. I've just said to Kathy, we'd quite like to bottle that enthusiasm around clinical audit. It's like the actual process that you've done there, and it's like you're converted into what clinical audit can actually do when it's done well. And you get those outcomes and that improvement. And I just wanted to stick my hand up and say thank you for that. And we're going to pass those details on to one of our anaesthetists as well while we're at it. So we will be passing you details on. Thank you very much for that.
Thank you very much.
Thank you.
Thanks, Zoe. Brilliant. So I'm not seeing any hands, so thank you so much for that fantastic presentation and worthy winners, and thank you obviously to John Ashcroft for joining us as well. I'm going to promptly hand over to Marina to take us through an interactive evaluation. You're just seeing a slide up at the moment that's just, or it was, challenging you to, sorry Sonia, we're confusing you, just challenging you again. These were some of the things we challenged you with in 22, still relevant. So we've left it in the slide pack really to try and just get you thinking as you go back to your own organisations. But yeah, over to you, Marina, to take us through that interactive Menti.
Thanks, Vicky. Yeah, I'll just share now. So as we have done all week, we're doing interactive evaluations for our clinical audit lunch and learn sessions. So if you can all just take a few minutes just before you all disappear to do our Menti. As you can see, just go to menti.com and enter this code. Or if you're doing it on a phone, for instance, you can just scan the QR code that's in the corner there. So just give people a few seconds to join us. It don't take very long at all, this evaluation, and we really do, you know, appreciate all the feedback that we get as part of these. I'm going up now. Everybody's joining us. So I shall move us on to the first slide. As I say, if you're still joining us, go to menti.com and it's 6441418. So our first slide then, as you'll see on your questions as they appear, just asking you to sort of tick along this sliding scale. So for the key speaker presentation, being interesting and engaging, having the right level of information, and have you learned something that you can use in your work? And then those 3 questions again, also in relation to the award winner presentation. So did you find it interesting and engaging? Did it have the right level of information? And have you learned something that you can take forward in your work? And then finally, would you recommend those lunch and learn sessions to others? As Vicky's put in the chat, all of our lunch and learn recordings will be available with the slide pack after next week. Please do share and encourage people to join our clinical audit networks, our regional clinical audit networks, and to chat with others through our forum as well. Fantastic, that's some really good feedback coming through. Thank you, everybody. Just move us on to our next slide. So we're really interested to know, what is your top takeaway from today's session? So what is it that you have learned from this session that you're going to be using in your work, you're going to be able to take forward? Just give everyone a second, just type those in. Yeah, it's so important to make audit meaningful, and, you know, yeah, the futures platform as well, improvement board. Yeah, it's easy to get involved in clinical audit and to make a big difference. It really is possible to make change. I think it's yeah, an important reflection that sometimes it can feel in the NHS like we're just a very tiny cog. But actually, you know, we really do have the power, no matter what our role is. We really do have that power to make an impact, to make a difference for individuals, for all of us, for our family and friends as well. Brilliant, more things coming through here. Yeah, in terms of the improvement programme, I think that's going to be really, really interesting to see about the leadership improvement training as well as part of NHS Impact. Yeah, it is. It's a great example of a project that's made a sustainable impact. So yeah, there's some great takeaways coming through, and so we will be capturing all of these along with all the other feedback that we've had through the week, and using that along with the feedback that our regional network members will be giving us. We're going to be putting all of that together to understand how everyone's engaged and the impact of this week. And then just our very final slide in terms of our evaluation. If anyone has any additional feedback about today's session, about the lunch and learn sessions, please do give us that feedback. We are all absolutely in the business of learning and improving. So, you know, if anyone has any comments or suggestions or feedback about today's session and the lunch and learn sessions, please do add those in. And I'll leave this slide open, and then if you want to do that, then you can do, and I'll just stop sharing now and go back to Vicky, but I'll leave this open in case people are still responding on their devices.
Lovely. Thanks, Marina. Well, we're a few minutes over now, so it was just really to thank our key speaker again, John Ashcroft, and obviously our worthy winners as well of the Clinical Audit Hero Award for Sustainability. And we are closing Clinical Audit Awareness Week today, aren't we? So it's just to wish you all a fantastic afternoon with your last of your activities. But as we've said, it's not just about this week, it's about what we're doing every day within our roles as we're trying to improve health and care. So we wish you the best of luck for taking forward all the information that you've listened to this week and received back into your own organisations. Don't forget, the recordings and slide packs will be made available next week as soon as we've managed to download recordings and upload everything for you. Helen's just put a link to the NHS Futures platform as well in the chat. So if you've not yet registered, please do try and get on there, because that's about taking action on National Clinical Audit. And a plug for next year, obviously, for Audit Awareness Week. Let's see some more worthy clinical audit submissions put in for those Clinical Audit Hero Awards. So thank you so much for engaging with us this week, and we do hope that you found them some really useful events to motivate you and inform you back in your own organisations. So have a lovely weekend when you get there, care, and hopefully we'll see as many of you as we can at maybe the open meeting on the 29th of June. Take care.